Okay, great. It looks like all 12, and I think we're expecting 13, so I think we're ready to go. So we're going to get started here. I'm Gina Upchurch, and I am the Executive Director of Senior Pharmacist, which you're going to hear about in just a minute. And we are thrilled to have you join us. We normally do these in person with the State Department of Insurance SHIP staff, but we are thrilled to sort of take this on ourselves and with some help from the state SHIP office to get the slides and stuff. And then Bruce, who's one of our wonderful volunteers and the coordinator of our SHIP volunteers. So I'm gonna have the panelists just introduce themselves if you don't mind. And Bruce, let's start with you.
Hi, I'm Bruce Hayes. I live in Durham. I've been a SHIP counselor for about 7 or 8 years, and about just on my 4th year in Durham, and happy to be presenting this today.
Thank you.
I'm Katrina Naismith, and I'm the Community Service Director. I'm the SHIP coordinator for senior pharmacists. And Bruce and I work together very closely.
Thanks. And I'm just going to give a little shout out to Katrina. She has got her master's degree in social work. And this past weekend, I'm publicly embarrassing you, she got her master's degree in health services administration. So she has a double major and is a workhorse. So Katrina, thank you for all that you do for us. She's relatively new to us, about 6 months, and we're just sort of getting on board. I'm Gina Upchurch. I'm the Executive Director of Senior Pharmacist. I am a pharmacist. I did a residency in geriatrics, and my public health graduate school program led to what has become Senior Pharmacist. It's been going 26 years come June 23rd, which is crazy. I earned these hairs that you see here. Lorna Doucette, who's also on the call, is an intern with Senior Pharmacist, and she is going to be helping us with a very cool project working on medication reconciliation in Durham. Whether you're going in and out of the hospital, in and out of a skilled facility, if you have rehab, living in the community, we often aren't on the same page when it comes to medications and people understanding what they're taking and how they should be taking it, and whether the provider's on the same page. So we're thrilled she's joined us on this today, and she wants to be trained as a SHIP, get some SHIP experience herself. So with that, I'm just going to continue the slides here. And so the first part is going to be just an overview about Medicare, and Bruce is going to do that. And then I'm going to talk a little bit about COVID-19 and what Medicare is doing about that. But let's first hear about senior pharmacists. So if you call 1-800-MEDICARE or the state SHIP Seniors Health Insurance Information Program office in Raleigh, they will give you our number. That is because we are the coordinating site for SHIP. We get about $20,000 to $25,000 a year to do the work. It costs us $250,000 to get it done. So we're independent nonprofit charity. So we raise a lot of money to do this. We consider Medicare an equal opportunity confuser. So whether you're rich or poor, young or old on Medicare, you need help oftentimes understanding it because it's not simple. That'll be the main message you get after this call, after this training today. The senior pharmacist, of course, does Medicare counseling, if you look at the far right, for any Durham resident, any age or income. Most of the year, we focus on helping people 60 and above with more limited incomes pay for medicines. I'm sorry, I need to back up. If you have a question or want to say anything, you will type it into the chat. So if you're hovering, you should see something called chat, and it looks like a couple of things are already in there. Congratulations and thank you. So y'all are already used to the chat. But if you want to ask a question, I apologize, we cannot hear your voices. You're all on mute in webinar style, but please do type your question there. During the presentation, we'll stop at certain points to answer the questions, and certainly towards the end, we will try to answer all of your questions. You also, after this, if you still need to be seen at Senior Pharmacist or want an appointment with us, you will call the office. Katrina will get back with you and ask you some questions to see when you need to come in. We don't see people months and months ahead of time just because things change and we'd be wasting your time and ours. But 3 months before you get Medicare is a time to come in. 3, 2, or the month before Medicare is when we see people. So she will schedule you for that. So you'll have an opportunity for that. But please feel free to use the chat because Katrina and I are monitoring it as this conversation goes by. So most of the year, we're focused on helping people so they have Medicare first, and then we give them a card that they can use at the pharmacy to lower their copayments even further. Local clinicians decide what we pay for. So most of our budget is, we raise money to help lower copayments so people can afford the medicines they need. The third thing we do is community referrals. So senior pharmacists realize that people don't live in a bubble, even though we're trying to live in a bubble during COVID, pun intended, but people have other needs. And so we tried, Katrina and two of her colleagues are really trained to tap people into other community resources to help people be as engaged and as independent as they can in our community. And lastly, we have, in addition to myself, 3 other clinical pharmacists that are much more gifted than I. And we help people up to 300% of the federal poverty guidelines with something we call medication therapy management. So we set up appointments. Now we're doing it over the phone or video to review medications to make sure medicines are doing more good than harm. For every $1 we spend in the United States paying for medicines, we spend $1.36 paying for medication-related problems. Medications can do great good, but they also can be harmful depending on how they're taken. So we work closely with providers. We have access to Duke's electronic health record for the people that we see. If we need to go in and see labs and that kind of thing, our pharmacists can do that. So we're very proud of that work. So that is sort of what we do. And the other thing I would say, if you know anybody, any age, who can't afford their medication, they really should be in touch with us. We can screen them for drug company assistance programs, whether they should go to Lincoln Community Health Center, that kind of thing. We do a ton of advocacy. We are involved with the American Geriatric Society Public Policy Committee. We advocated fiercely for some changes to the Medicare website. And Bruce, I don't know if you've seen, but they have been made, and the Medicare Part D website changes have been made. Not all of them, but many of them. We are thrilled. We are thrilled with that. And the other thing we would say is that the only way senior pharmacist is successful is if the older adults or the individuals with Medicare that could be younger are engaged in their own health care. We don't pretend to think we know more about your health than you do. So we just are here to help facilitate you advocating for yourself. So our motto is know your meds, know your coverage, know your rights. So that's sort of who we are. With that, I'm thrilled to hand it over to Bruce Hayes, who, by the way, was the statewide health volunteer of the year with the Department of Insurance, not Department of Insurance, but the Volunteer Centers of North Carolina last year. So he's won all sorts of accolades for his work. So Bruce, to you, thanks.
Okay, thank you. So the first thing is, what is Medicare? And as Gina mentioned, it's pretty complicated. It's filled with these small rules and nuances. So, the idea here is not to overwhelm you. It's to give you basic information so that you can continue to ask questions of the people that you're consulting with. So Medicare is health insurance for people, meaning individuals. So it's not family members. So those of you who may be coming from a work environment, employee insurance, Medicare does not offer group plans or plans to families or individuals. So if it's you and a spouse, you each will have to go through the Medicare sign-up process, and you will each have your own unique insurance. Could be the same, but it may be different. It's for people 65 and older, or under 65 with Social Security approved disability. Any age if you have end-stage renal disease, or you have ALS or Lou Gehrig's disease. So that's who qualifies it. It's administered by the Center for Medicare and Medicare Services, CMS. So if you get any mail that has CMS on the envelope, do not throw that away. That may have some important information about Medicare. And Social Security's role is they enroll most of the individuals to begin Medicare. If you happen to be a retiree of the railroad system, then the Railroad Retirement Board may be the one that enrolls you. And just a note, to be eligible, you have to be a U.S. citizen or lawfully present in the United States. So that's what it takes to be part of Medicare. Okay. Next
Sorry.
one. Okay, so these are what's basically referred to as the 4 parts of Medicare. Part A, which is your hospital insurance. So that covers everything while you're in the hospital as an admitted patient. And we'll go over that in a little while. It's very important to differentiate when you just go in for observation or anything else versus an admitted patient. Part B is referred to as medical insurance, which is everything else that a provider may give you, such as a doctor, a clinic, outpatient center, test facility, diagnostic facility. That's covered under Part B. Part C is referred to as Medicare Advantage plans. You may have some familiarity with HMOs and PPOs if you had employer plans. So Part C is a plan that is managed by an independent insurance company, and the government provides funds so that the insurance company under Part C or Medicare Advantage includes your Part A and Part B, sometimes your Part D coverage for medicines, and sometimes other benefits, which we'll go over in a few minutes. And the last part is Part D, which is your Medicare prescription drug coverage. So you pay a premium, and then your insurance plan, which is again through a independent insurance company, such as a Humana or WellCare or Cigna, one of those, will administer the prescription drug coverage. So those are the 4 parts of Medicare. So this is, you'll see this slide a few times during the presentation. This is important. This is showing you, as a person new to Medicare, the 2 different choices you have, 2 paths as we refer to them. On the left side is what is referred to as original Medicare. In original Medicare, you get your Part A and your Part B from the federal government. So Medicare is taking care of your Part A and Part B costs. And then you can buy what's called a Medigap or a Medicare supplement plan, which covers the costs in many plans that Part A and Part B do not cover. And in addition, you can get a Part D prescription drug plan. So anything that you do there on that side is considered original Medicare. And we'll go into the cost of each of those in a few slides. Your option, as we discussed before, is Medicare Advantage on the right side. So Medicare Advantage is a managed care, meaning that as I said before, an insurance company gets money for you from the federal government, basically to take care of you and to manage your health care. So they provide parts A and B, and in addition, they will provide typically Part D, although there are some that don't, but most do. And then they also offer some additional benefits, such as a little bit of dental, a little bit of hearing coverage, a little bit of prescription coverage, and sometimes some other benefits. And we'll go into the differences in a little more detail in each. But keep this in mind. You'll see this slide several times through the presentation. Left side original, right side Medicare Advantage. Okay? Okay, so we mentioned Part A is hospital coverage. And hospital coverage includes inpatient hospital care, meaning that you've been checked in, admitted to the hospital. It covers inpatient skilled nursing facility care if it's determined that you need to go to a skilled nursing facility. It'll cover blood. It'll cover certain inpatient, other items, non-religious, non-medical health care, and approved religious non-medical institution. It'll provide home health care, and it'll provide hospice care. And just to be clear, home health care is not the same as long-term care insurance. So home health care is when your physician determines you need assistance at home related to the reason, related to your health. It is not providing long-term care like you may see advertised. Okay. So signing up for Part A, enrollment is usually automatic. Social Security will send you a card, especially if you are getting Social Security. It's typically premium free if either you or your spouse paid, if you remember on your paychecks, FICA, for 10 years. So it would be either you or a spouse. If you have fewer than 10 years credit, then you may have to pay some monthly premiums. So if you are still working, you need to speak to your benefits administrator if you're covered by an employee plan to find out if you need Part A. And also if you are part of a health savings account, you need to stop those contributions prior to enrollment if you want to maintain that tax advantage. So that's why it's very important to start doing some work, like Gina was mentioned at the beginning, to be your own advocate, to find out what you're entitled to, what the restrictions are, what the requirements are, be familiar with the time frames, because all those are very important. Okay? Okay, so Part B is referred to as medical insurance. Part B typically covers about 80% of the allowable or approved amounts. And that includes doctor services, outpatient medical surgical services and supplies, clinical tests, durable medical equipment, diabetic supplies, and preventive services. So when you're using Part B, if the allowable charge from a physician is $100, for example, then Medicare is going to pay 80 of that. You're responsible for the other $20 unless you have additional insurance. Okay, so signing up for Part B, Social Security will typically enroll you in Part A and B, and they'll send you a card if you're collecting Social Security when you turn 65. If you are covered by an employer plan, and you're still working at employer, you have to notify Social Security to delay Part B. Otherwise, they're going to start taking out the Part B premium from your Social Security check, or they will start billing you for Part B. Right now, that charge is $144.60 a month minimum. So you want to make sure you pay attention to that, because if you go 6-8 months and you forget about it, they will not refund you that money. If you're collecting Social Security, your Part B premium will be deducted directly from your monthly check. If you're not collecting, you'll be billed quarterly in advance. So if you're not on Social Security, but you started Part B, then you're going to have to pay $144.60 times 3 just when your Social Security starts. You may have to pay higher premiums if you have a Part B late enrollment penalty or have a higher income, which is called income-related monthly adjustment amount, or it's referred to as IRMA. And we'll show you in a minute what those fees are, because they can be pretty substantial. If you meet income requirements, you also may qualify for help in paying for your Part B premium through the Medicare Savings Program. And that's one of the things, if you work with senior pharmacists, they will help you to understand what other programs you may be eligible for. Okay, so this is a summary, a brief overview of what the cost of Medicare are. Now, again, this is only A and B. This is not considering whether you have other insurance, a supplement or Medigap plan, or if you have a Medicare Advantage plan. So the Part A premium, as we mentioned before, is typically premium free as long as you have a qualifying work history, meaning you worked for 10 years or 40 quarters and you made at least a certain number of dollars. If you don't, then it could be $450 each month, depending on how much time work credit you do have. So for Part A, you pay a $1,408 deductible for each benefit period. And that's for 2020. So that's typically looked at each year, and it could go up. And what that means is benefit period is a period of 60 days following when you get out of hospital or skilled nursing facility. So for example, if you had a problem and you checked into the hospital January 1st and they released you, they admitted you, they released you on January 3rd. If you had to go back in the hospital again on March 5th, you would be responsible for another $1,408 deductible because your 60-day benefit period is over. If you had unfortunate luck of getting sick again in July 10th, you could have to pay for another $1,408 deductible. And that covers day 1 through 60. There's no co-insurance. And just terminology-wise, a copay is typically when you go up front and they'll ask you for the money ahead of time. So like if you go to a doctor's office, they'll say there's a $20 copay. You'll pay that amount. Co-insurance could be either a payment or typically a percentage. So in this case, after day 60, you pay $352 a day for each day of the benefit period. And the 91 days and above, there's further insurance referred to as lifetime reserve days, but I won't go into that detail. Part B premium, as I mentioned before, is $144.60 a month. And the reason for that is because when we worked, we contributed money to the federal government through our FICA deduction, which went totally towards Part A. So we made no contributions as employees to Part B. So the federal government now is charging us a premium to pay for part of that Part B expense. And as it says here, high earners may have to pay more. Part B deductible and co-insurance. So there's $198 per year Part B deductible. And then it's 20% co-insurance after that. So as I mentioned, so if you went for a test and that test was $1,000, Medicare would pay 80% of that. You would have to pay the balance of the $200 if you had no other insurance. So those are the basic costs. And in addition, to keep in mind, there are about 30 items which are considered preventative services, and those are mandated by Medicare to be fully paid, no deductible, no co-insurance. So things like annual wellness exams, colonoscopies, mammograms, things of that nature, diagnostic tests are considered preventive services.
Bruce, we have a question in the chat, and I've answered it, but for those of you who aren't following the chat, the question is Part A free only if one person or their spouse have had FICA or payroll taxes paid into it 10 years or more? And the answer to that is correct, but it could include somebody you're divorced from. So I think you have to be married 5 years. Is that correct, Bruce, for it to be?
I think it's 10.
Is it 10?
Yeah.
I know there's a 10-year work history. I thought it was 5 years of marriage.
Yeah, 10 for divorce, yeah.
Okay, so 10 years. You have to be married for 10 years. It includes same-sex. Social Security Administration includes same-sex couples. So you can, even if one person never worked, they could get Medicare premium-free A if they were married to someone who was paying FICA taxes for 10 years. It doesn't have to be continuous. You could have worked 5 years and then not worked and then work another 5 years. And just 40 quarters of payroll history gets premium-free A. Okay. Yep. So the other thing that I realize, this is new, but Zoom, I can allow some of you to talk through mute. I'm unmuting you. That used not to be available in the webinar style. So if you also want to put something in the chat asking to unmute you, we can have you ask a question and we'll take breaks throughout the conversation. So Bruce, back to you. Thanks.
Okay. All right. So this is basically the chart for higher income earners. And keep in mind that when, as a default, Medicare and Social Security look back 2 years in your income. So if you were to retire in 2020, for example, they're going to base their adjustment on your 2018 taxes. And you'll see it says a modified AGI with a star. So that's adjusted gross income. And what they do is they take the adjusted gross income on your tax return and they add back in any tax-free income that you might have had. So if anybody has a tax-free bonds or tax-free mutual funds, they add that into what's on your adjusted gross income on your statement. So keep that in mind. If if somebody sold a business 2 years ago and now they have low income, they're going to base it on the income you had 2 years ago. You can go down to Social Security and explain that you have a change in situation, and they will often make an adjustment. So you'll see there's an adjustment both for Part B and for Part D. So for example, if you made less than $174,000 as a couple, or you made less than $87,000 as a single person, then you would just pay the standard $144.60 for Part B premium, and you wouldn't have any surcharge for your Part D. But if you fall into one of those 5 categories, you'll see that it increases the more you make. So for example, if you as a couple made $273,000, each person that's on Medicare would be paying $376 instead of the $144. And in addition, you'll pay an additional $50.70 a month for your Part D insurance. And so you can see it goes anywhere from $202 to $491 for Part B and $12 to $76. So that's something you need to keep in mind, especially if you're deciding whether to go off a spouse's insurance. So for example, I've had somebody who was a very high earner just trying to decide whether to go on Medicare. Well, if he didn't go on Medicare, he would have saved the $462 a month because he'd still be on his wife's, and his company plan did not require A and B. So you really need to make sure you're reviewing this with your benefits people, and hopefully, when you come in, the senior pharmacist, we can help you to understand the potential IRMA adjustments.
Okay, we just had a couple of quick questions here, and that we're going to go into Part D in just a minute, so hold off on the questions about Part D, the drug benefit. The 2 years, you said they're going to look back 2 years. They're only looking, so if we're 2018, they don't average any 2 years. They just look back at 2018 right. Taxes. Exactly. So they look back 2 years. And if you've had a change, you need to let Social Security know. Social Security does not have open doors now, so you can go call the local number or the federal number, and they are handling things over the phone. You can also do Social Security to start your A and B online, SSA. Right. You can delay B online. If you've delayed B and you want to start B eventually, you cannot do that online. You have to be in touch with Social Security about that. But they don't take 2 years. They just actually look back 2 years. But if right. your situation has changed because you've quit working and you don't want to pay that IRMA, as they call it, you definitely just need to let Social Security know that and have some proof of that, I guess. I don't know what kind of proof they need.
Yeah, when I retired, I brought with me the tax return for the upcoming year to show them used to be making this much, but now my income will only be this. And then they did an adjustment right there.
Yeah, thank you.
Okay. Okay, so Part D is, again, the Medicare prescription drug coverage, and it's available to anybody with Medicare A or B. So you have to have one of those two. You have to have signed up, and it has to be effective in order to get a Part D plan. It's provided through prescription drug plans or through Medicare Advantage plans and a few other specialty plans called PACE and others. So having a Part D plan is optional. You don't have to have it. However, if you don't join when you're qualified and you don't have other creditable prescription coverage, you may have to pay a penalty to join later. So creditable coverage means that you have coverage which is at least as good as Medicare. So for example, when you, if you retire from an employer plan, Social Security will ask for a statement from an employer that you had creditable coverage during that time, so you don't get a penalty. And the penalty, if you did, so let's say you said you're healthy, you don't take any medications, I'm going to put it off for 3 years. If you don't join in those 3 years, you're subject to a penalty of 1% per month of what they call the base fee, which is around $33, $35 this year, for every month that you didn't join. So if you waited 3 years, you would be subject to a 36% penalty, and that penalty is for the rest of your life, as long as you're on Medicare. So every month you would be paying a 36% penalty. So the recommendation is you get a plan, you know, the lowest cost premium, so you avoid that penalty, and in case a surprise comes up and all of a sudden you need a medication, you do have a plan to cover you.
Bruce, just a question. So the question that came up is the Part B and D surcharges for somebody who has IRMA. They're separate amounts, but they're both paid to Social Security, right? And the penalty is paid to for D is paid to the company.
Yes.
But IRMA's all goes straight to Social Security, and they are separate amounts. They get added together. Okay.
Yeah,
thanks.
they'll be shown separate
On the Social Security statement.
Yeah.
Thanks.
So the next thing is that each plan that you choose has what's called a formulary, which is a list of covered drugs. And the formularies have to include a range of drugs in various categories, but they do not have to cover every single drug. So that's why it is very important each year during open enrollment, you review the medications you're taking, because what may have been covered this year under your plan may not be covered the following year under that same plan. So every year, it's really important. It could cost you a lot of money. So for example, for me, last year, one of the medications I took that the plan decided not to cover, if I didn't change plan, it would have cost me $7,400 a year more. So it's really important during that open enrollment period from October through December, middle October through December 7th, that you review it and make adjustments as necessary. You have to pay a monthly premium, and you pay the deductibles, co-pays, or co-insurance, which we'll explain in a minute. If you have limited income and resources meaning savings accounts, investment accounts, and those things, you may qualify for help in paying for your premiums, deductibles, and the co-pays. The program is called Extra Help. It's offered through the Social Security system. And again, the folks at FEMA pharmacists can help you to understand what you qualify and get applied for that program. Okay, in terms of joining Part D, again, you have to have A and B. And you have to have A and B. To have a Part D plan, you have to have A or B. To join a Medicare Advantage plan that includes drug coverage, you have to have A and B. You have to live in the plan service area, typically by state. So in other words, if you took if you lived in California and you had a drug plan, a Part D plan, if you move to North Carolina, you have to notify that company, and likely they will either if they offer one here, they will have to change your plan. So it's only good in your area. If you're incarcerated, you're not entitled to Part B, or if you live outside Part D. If you live outside the United States, you're not entitled to Part D. Okay, so when can you enroll? So you can enroll initially during what's called your 7-month initial enrollment period. So for example, if you are born in May, then you can join a Part D plan and sign up for Medicare the 3 months prior to May. So you could start signing up February, March, and April. You could sign up in your month you're born, and then you can sign up for the 3 months after. But if you delay it until after your birth month, then you're not going to have coverage for 1 or more months. You also can sign up during the yearly open enrollment period I mentioned before, which is from October 15th through December 7th. And when you do that, the coverage begins the next January. So that enrollment period is provided so people can review their prescription coverage and make changes. So prior to that, if you already have a plan, you'll get what's called a notice of change from the plan. It'll be a pack of documents that you get, and that's where it'll tell you if they're not going to cover a drug, changes to their formularies. You also may be able to join or switch plan at other times. So from January 1st through March 31st, they have what's called the Medicare Advantage open enrollment period. So if you're in a Medicare Advantage plan, you can make a change for anything that you may have signed up for during the open enrollment period from October and December. You also get what's called a special enrollment period if you are part of that extra help program mentioned before, if you live in a skilled nursing facility, or if you leave a service area. So again, if you lived in Durham and moved to Virginia, and you're entitled to a special enrollment period because the plan doesn't cover you in the new state you're living in. And there's a little information to apply for the extra help program. Again, you can contact senior pharmacists. They'll set up an appointment to help you. You can apply online at socialsecurity.gov/extra help, or you can call or go to your local Social Security office. But again, right now, I think they're only taking phone appointments because of the COVID-19 situation. Okay, so should you enroll in Part D? You have to consider, do you have credible drug coverage? For example, through employer plan or the VA. There's no penalty if you have creditable coverage and delay in enrolling in a Medicare drug plan. So if you're covered by an employer and it's a creditable plan, you don't have to enroll. You need to determine, will that coverage end when you retire, and what are the requirements of that plan? How much do your current drug cost? And what is your overall cost with Part D using what's called the CMS Plan Finder website? So that'll help you look up, if you know, or a senior pharmacist can help you navigate through that to understand what's the best plan for you. So if you don't have creditable coverage, as we mentioned, you may have to pay a lifetime penalty if there's more than a 63-day lapse in coverage. Okay. And this is just a picture of what the Medicare Gov website did look like. They're constantly changing it.
Yeah.
So, but if you go to Medicare.gov and you find sign up change plans, then you can go through it. Again, it's easy to get to. Understanding the different options and plans is where people typically need some assistance.
We'll update the slide for our next presentation because the website has changed.
Yeah.
They do ask you to create an account, that you can do. And the nice thing about that, you need to create a username and password, but then you can look up claims, print out Medicare cards, put your drugs in, they'll be saved from year to year. But when senior pharmacists is seeing people, we actually help people set up accounts if they need help. So from year to year, things will stay, and it'll be a much more efficient process from year to year if you're looking for a drug plan. Just FYI. So they'll ask you to create an account. We do not give Medicare your email address unless you want to be totally, because what we're finding out is there are a lot of scams. We had a staff meeting this week, and one of our participants was telling a staff member that we got a call, actually it was at our participant advisory council meeting yesterday, that says they were from Medicare and they wanted to help her laminate her card, and should she give them the number, and then they'd laminate it and mail it to her, and that's all a hoax. That's all a scam. Nobody from Medicare will ever call you. Nobody from Social Security will ever call you unless you called them first. So it's all through the mail, or we don't even give email, because then people fall for this stuff that's coming through email that looks like it's from Medicare, but it's really not. So just be super careful, because there are a lot of scams out there now. I would also just share with you, before I forget, Part D savings from senior pharmacists. This past year, when we help people, we save them on average $777. As Bruce said, you can have major savings by switching drug plans from year to year. So it's not chump change, it's fairly significant. And people with more limited income saved even more money. So just FYI. And I would just add one other thing in terms of whether you delay B, if somebody's actively still working, it depends on the size of your employer also. So if you're a younger person with disability, you have to have an employer of 100 or more people. If you're 65 and older and wondering to delay B, to be considered primary coverage, your employer has to have at least 20 employees, full-time employees, to be able to delay B and still have your employer be primary coverage. So it depends on the size of your company. If you're with a big company, no problem. If you're with a small company, it matters how many full-time employees they have, whether you should delay B or not. So I just wanted to put that out there. It's just a little bit of a precaution. If you have a small business, that will usually not be primary. Medicare will be primary when you turn 65. Okay, next.
Okay, so this is an attempt by many to explain the Part D coverage levels. It's very confusing. I'll start with the deductible because of the question before. So some plans have what's called a Part D deductible. So Medicare allows plans to charge up to $435 deductible. And what that means is you would have to pay the first $435 of covered medicines. However, that typically only applies to what's referred to as higher tier medicines. So the medicines are typically structured into tier 1, 2, 3, 4, and 5. Tier 1s being a common generic, in which cases many plans, if not all, either give it to you free or a couple of dollars. Tier 2 is a generic. Tier 3 typically is a branded drug, and so forth. So the tier 1, 2, and 3s in most plans do not count towards the deductible, so you don't have to pay that. But if you are taking medications, a tier, a higher tier drug, then, if your drug was $200, you would have to pay the $200, and that was the only one you took each time until you paid $435. Then your plan would start coverage. So that first phase is called the deductible. The next phase is partial coverage limit, where the plan will pay up to 75% of the medication. You'll pay 25%. Once you get to a total of $4,020, then you'll enter what is called a coverage gap. It was also known as the donut hole. So the donut hole in general has really disappeared in terms of coverage levels, other than there is an out-of-pocket threshold of $6,350. After you reach that, then you go into catastrophic. So during initial coverage, the plan pays 75%. During the former coverage gap or the donor hole, they're still paying 75. When you get to catastrophic, now the plan pays 15% and Medicare pays 80%. So you only have to pay 5%. The bad news, of course, is that you've already paid a lot of money out of your own pocket. So those are the different parts of the Plan D. And when you look for different plans on the Medicare.gov plan finder, it'll show you what the coverages are in each of those segments for the different medications you take. Some will have copays during some of those and won't be necessarily 75%, but this is generally the structure of the Medicare Part D. Gina, you want to add anything to that?
Yeah, there's a question that's come up and I'll add something. So during the deductible phase, what we're seeing now, and this is new this year, a lot of the very inexpensive generics will be little to nothing during the deductible phase. They will give you the discount up front. It's usually the brand name drugs you have to pay that deductible. It used to be for all meds, you would have to pay everything in the deductible phase, but they've changed that. So it's super confusing now. The Affordable Care Act is what's filling in the coverage gap or donut hole. If the Affordable Care Act is repealed because it's gone to the Supreme Court again for another case, it keeps going back and forth. It's been here with us 10 years. They're still questioning it. If they do that, the donut hole is back again. So people that have to spend a lot on medications would be, right now, the way it's set up, would be responsible for all of that payment between $4,000 and $9,719. So just keep your eyes on that. That is part of the Affordable Care Act, as well as preventive services with Medicare not costing anything. That's all part of the Affordable Care Act. And extra payment to Medicare Advantage plans, part of the Affordable Care Act. So a lot of people think Obamacare or the Affordable Care Act is just for younger people. It dramatically changed Medicare, in my mind, much, much for the better. So we'll just need to keep our eyes on that.
Yeah, it's not just insurance.
That's right. That's right.
Not just the insurance premium.
Right. The other thing I would just add is Part D plans are sold by state. They will work anywhere. I could buy a Part D plan in North Carolina and go to a pharmacy in Timbuktu. It'll work just fine. I just pay the premiums based on what state is my residency. There are preferred versus non-preferred pharmacies, so you sometimes can get a little more of a discount in preferred pharmacies, but it can be covered. Almost all pharmacies take all cards now, so that tends not to be a problem. Medicare Advantage plans are sold by county. Part D plans are sold by state, just FYI. Thanks. Oh, already said that. Okay, I didn't know that was in there. We save people money.
Yeah, this is just, again, a summary of savings senior pharmacist provides.
Okay.
All right. And this is a little bit about the extra help, or it's also referred to as low income subsidy, LIS. So there's different levels. You may hear it referred to as full and partial extra help. And if you, it'll reduce your cost of the medicines also. Okay, so now aside from the, remember on the chart A, B, C, and D, this is Medicare supplements or Medigap. So the rules for supplements are set by the Medicare, but they are sold directly from the individual companies that provide them. So you'll see they're sold by private insurance companies. And again, it bridges the gap for costs not covered by Part A and B. So if you, have to see a doctor regularly and have tests regularly and have other health conditions, if you're in a Medicare Advantage, because it's a pay-as-you-go, then those costs could add up. So typically, for example, if you go to a doctor, it could be a $20 copay for a primary physician, a $40 to $55 copay for a specialist, and then coinsurance for diagnostics and others. A supplement will cover the things that A and B do not. So for example, you'll see there's different types of plans, A, B, C, D, G, so forth, that are allowed to be offered in North Carolina. You'll see that C and F are grayed out. So C and F are not offered anymore, other than to people who qualified to get them prior to 2020. And the reason for that is if you go down towards the bottom, third from the bottom of the chart, you'll see Part B deductible. If you remember, that was the $198. So those two plans covered the Part B deductible, and the government decided that was not a good idea anymore. They wanted everybody to have some contribution into the plans. So C and F are not available. So the most comprehensive plan, the one that we typically recommend to people, is the Plan G. And you'll see Plan G covers everything except that Part B deductible. So if you went to a doctor and the bill was $200, you would have to pay the first one, that $198 towards the deductible for the year, and then you're covered 100% for the rest of the year. So there, like I said, most plans don't require copays or deductibles. The costs vary by company, but coverage is the same for the plan type. And this is usually very difficult for people to understand. So if you look at Plan G, you'll see that there are 30, 40 different companies that offer Plan G in North Carolina. And the cost of those plans for a 65-year-old female, for example, is about $93 a month, all the way up to about $230 a month. So the thing to understand is no difference in the coverage between those two plans or any of the 40 other than the cost. That's mandated by the Medicare regulations. So you get the same coverage for any plan. It's just a matter of your preference as to which company you want to go with. Because of the way it's structured, the costs vary by the plan type. And an important item is that you have a guarantee issue right for a limited time. So let's go to the next slide if you could, Gina. So let me explain that. So during your, when you turn 65, you have what's called a guaranteed issue right for 6 months to sign up for a Medicare supplement plan. And what that means is if you're a 65-year-old female, they have to offer you the plan at the same rate as they do for any other 65-year-old female, and they can't consider any pre-existing conditions. They just have to sell you that plan. After 6 months, if you decide you're going to do a Medicare Advantage for a couple of years, and then 3 years later you say it's not working for you, or you develop some condition, you can apply back to try to get Medicare supplement. However, the companies now have the right to put you through what's called medical underwriting, meaning they can ask you a series of medical questions, and then their underwriters will make a decision on what to do. They can either offer you the policy at the same rate as everybody else. They can say, we'll offer you a policy, but we're going to charge you more. And it could be whatever they want, $200, $300 or more. Or they could say, we're not going to sell it to you. And the laws allow them to do that outside of that guarantee issue right period. Now, there are a couple of, as I said before, there's a couple of exceptions to it. During the first 12 months, if you chose a Medicare Advantage and decided you didn't like it, you do have a right to go back. And there's some other conditions. But in general, when you're making a decision on whether to go on original Medicare or Medicare Advantage, you need to keep that guarantee issue right in your mind, because if you develop things, like cancer or kidney disease or liver disease or other heart problems, or you have surgeries down the road, you may not qualify to go back. You may not have that choice anymore. Okay? So, in terms of choices that you have, original Medicare, again, it's usually referred to as a fee-for-service. You have Part A from Medicare, Part B, doctor and outpatient Medicare. You can have secondary coverage either through a past employer. If you qualify for Medicaid, it serves as your secondary, or you can purchase a Medigap Medicare supplement plan, and you can purchase a Part D drug plan. The advantages to that side is that anybody who accepts Medicare will accept your insurance. So you can go any place in the country that accepts Medicare, any hospital, any other provider. There's no networks. There's no maximum, any of those things. If you choose Medicare Advantage, Parts A and B are combined into C. It's paid for differently with co-pays and co-insurance. So for example, when you go into the hospital with an Advantage plan, you may have to pay $295, $395 a day for 4, 5, or 6 days. You're typically not paying a monthly fee. So many of the plans are 0 monthly, but it's a pay-as-you-go. Original Medicare, you're going to be paying that $90, $100 something a month, but no more pay-as-you-go. So that's the difference. But again, remember the guarantee issue right. If you choose the Advantage plan because of the lower monthly cost, and you have develop conditions, you could end up paying more. A lot of the plans have a yearly maximum out of pocket, which up to $6,700. So that's your liability. On the original Medicare side, you only have $198 liability. As I mentioned before, it can include extras. So many of the plans include vision benefits, dental benefits, hearing aid benefits. They're not fully comprehensive. So if you need, 6 crowns made, that insurance is not going to pay for that. But they'll typically pay for cleaning and x-rays. They'll pay something towards glasses and other stuff. On the original Medicare, up until recently, they were not allowed to provide any kind of supplemental benefits. But now we are seeing some that are provide. I think United Healthcare and Blue Cross will include gym memberships. Some of the others, like Aetna, have purchased discount programs that members, so you can get a card for discounts on vision and dental. They can't pay directly, but as a member, you're entitled. So again, you need to review them carefully. So what does Medicare not cover? So Medicare does not cover prescription medications. A Part D plan will. It doesn't cover routine dental care. It doesn't cover routine vision care and eyeglasses. It does cover eye conditions related to eye health. So if you have to go in and they have to do examinations because of glaucoma or other problems, that are covered. But anything like related to refraction for glasses to determine prescriptions, that's not covered. Hearing aids, foreign travel, cosmetic procedures and treatments, and long-term care, as I mentioned before. So I had somebody a few months ago said that Medicare wouldn't pay for their cataract surgery. And I said, well, that's kind of unusual. Maybe I can help you figure it out. And after talking to the lady, it turned out, she said, well, they actually did pay for the cataract, but while I was there, I asked them if they could lift my eyelids. And I said, okay, well, that's different. That's cosmetic procedure, unless a part of your vision is blocked. They have a specific standard. So they're pretty careful about that. Okay, so as we talk Medicare Advantage, it's another way to get your coverage. It's still part of the Medicare program. It's run by private companies, so you can sign up for it through Medicare. Medicare pays the plan an amount for each member's care. So each month they're giving what they would normally cover for you for A and B. You may have to use network doctors, hospitals, rehab facilities, so forth. So it's one of the disadvantages of the Medicare Advantage plan is that you're limited to those networks. If you have to go out of the area or you want to use a specialist and that person's not in the network, then you may not be covered. The types of plans available and their costs vary by county. So if you join the Medicare Advantage plan, you're still in Medicare with all their rights and protections. You still get the services covered by A and B, but the Advantage plan covers them, not Medicare. So if you go into a provider, you're going to give your card, you're going to give your Advantage card. You don't really need to present your Medicare card because they're not going to be billing Medicare. You may choose a plan that includes prescription drug coverage, and you can choose a plan that covers, includes extras, and it may or may not have a premium. Okay. So when can you enroll in an Advantage plan? Well, just like we talked about Part D, during your initial enrollment period, that 7-month period circling your month of birth. During the open enrollment period, October 15th through December 7th, unless you have end-stage renal disease. And every year during that open enrollment period, you have the right to switch your plans. Okay, so just like the others, Medicare is giving the option. Medicare Supplement, for example, you can switch plan at any time if they'll accept you. So there is no open enrollment period for supplements. And then, as we mentioned, there's an additional Medicare Advantage open enrollment period from January 1st through March 31st. And you may qualify for a special enrollment period, of which there's a lot of qualifiers. But for example, if you move out of the plan's area, or the plan says they're no longer covering you, if you qualify or you lose extra help, there's a number of different situations which senior pharmacists, ship counselors can help you navigate through all those lists. Okay, so again, 2 paths: original Medicare, A, B, supplement, and Part D, or Medicare Advantage, Part C. Many include Part D. So those are your 2 options. So the decision is which one? The original Medicare, it's a fixed monthly cost. So you're just paying that premium. Choice of providers across the country accepting Medicare and new patients. Most of the plans cover the copay, co-insurance, deductible for Medicare services. No referrals or networks. So whereas in Medicare Advantage, some of them are HMOs, meaning if you need to go to an orthopedist, you might have to get a referral from your primary physician first. And most individuals have to pay a separate premium for Part D. If you go to Medicare Advantage, there's usually a 0 or low monthly cost other than the Plan B premium. So just need to make sure you understand everybody pays that $144.60. And most will include drug coverage. Again, it's a pay-as-you-go plan, meaning there's co-pays, deductibles, or co-insurance. Often offers some additional benefits. Many plans require to use a network, so you may not be covered out of the area except for emergencies. If you have an emergency out of state, for example, and then they have to admit you to the hospital, you're now out of network. As I said before, HMOs, many plans are HMOs, require you obtain a referral. And you can only join and leave the plan during certain periods. And there are limited, we call special needs plans available for people who are in institutions or on Medicaid. Okay. And just to summarize enrollment, it's automatic if you're receiving Social Security or railroad retirement. As we said, you have the 3 months before and after to enroll. If you're not automatically enrolled, you need to enroll with Social Security, either visiting them on site or calling them. And you should start the process as soon as you're eligible, to give them time to get everything in place. Okay, so here's just an illustration of the enrollment periods. Again, we said 3 months before and after. If you don't, as we said before, if you don't enroll in Part B and you don't enroll in Part D, you may have a late enrollment period penalty, and your coverage starts based on when you enroll. And keep in mind, you don't have to be retired to be in Medicare. You just need to be either 65 or on disability, qualified for Medicare.
There are two other groups that can qualify for Medicare immediately, and this has to do with lobbying years ago. That's people with end-stage renal disease or Lou Gehrig's ALS are the other two reasons. And that's sort of immediate. There's no wait. Like if you have a permanent disability, you have a 2-year wait.
2 years on, right?
Even though it goes back to when you applied, because it takes a long time to get disability, but it goes back to the date you originally applied.
Yeah.
Thanks.
Here's a little bit, I think we talked about the other enrollment periods, January 1st to March 31st. If you didn't sign up for Part B, but then your coverage is delayed until July. Penalties, as we mentioned, there's a Part A penalty if you don't qualify. There's a special enrollment period. There's about 20 different special enrollment periods depending on different situations. And one thing to keep in mind is, again, this is very confusing. If you are covered by COBRA, so if you're on a plan and then you stop, you lost it and you're on COBRA, you then turn 65, and for some reason you say, I'll just stay on COBRA for the remaining 11 months. COBRA does not count as creditable coverage for Part B. So if you don't sign up for Part B, then you will have a late enrollment penalty. COBRA does qualify as a creditable coverage for Part D. And of course, there's federal, state, and employer plans. They work a little differently. So if you're part of the North Carolina Employee Retirement Program or the Duke system or any others, they work a little differently. They offer different things. They can change them every year, depending on the employer, may have different requirements. Some have a different plan when you become 65. Some will carry over into the existing one. So that's why it's really important to review this well in advance with your HR person to really understand what they offer and what they require. So other things to keep in mind: sign up for Medicare as soon as you can. You have an 8-month special enrollment period to enroll in Part B without penalty. The sooner you enroll in Part B, the sooner your coverage will begin once you're eligible. Enrollment in Part B also triggered that 6-month Medigap open enrollment period. You only have 63 days to enroll in Part D after you're eligible to avoid a penalty, and your plan begins on the 1st of the month following the month you enroll. However, again, there's more exceptions. If your birthday is on the 1st of the month, then you'll actually be enrolled for the prior month. Again, you have to have Part B to buy a Medicare policy, join Advantage plan, have TRICARE for Life or CHAMP VA, or your employer coverage requires it if you have less than 20 employees. VA benefits are separate from Medicare. The VA benefit is creditable, but veterans can also enroll in a Part D or Part C if they choose to. Things keep in mind, again, check with your employer if you're turning 65 to determine if you have to have Medicare and the impact on a spouse if they're also covered. Some employers use they call a private exchange, meaning you have to use this company that they have hired to enroll in order to get the company's benefits. So you need to be make sure you're asking about that. We've had there's several companies in the triangle I know that are in that situation. If you don't, you could lose their benefits. Okay, so hopefully we've not confused you too much. Any other questions?
So if you've got a question, you can, thank you so much, Bruce. Let me start there. You're always excellent with this. And if you have questions, you can type them in the chat. I can also see if you raise your hand, which is a function. If you hover around, you can, I think where it says participants, you can click on that and you can raise your hand. I'm not sure exactly where it is on the screen. And we can call on you and I can allow you to talk. Well, you can talk all you want, but we can actually hear you. I can allow you to be heard, I guess is the way I should say it. Otherwise, we're going to get on and talk a little bit about COVID and Medicare. So any questions? Okay, well, you can be thinking of them. And at the end of this, if you have one, let me know. Okay, so I'm on the roller and I'm rolling it wrong way. All right, so I'm going to talk a little bit about seeing a couple things in the chat, but it sounds good. I want to talk a little bit about COVID and the response from CMS. CMS is Center for Medicare and Medicaid Services. As you all know, there was the CARES Act, and there was some information in there about Medicare, related to Medicare. So we wanted, and just other medical things we thought might be of interest to you. So first of all, viral testing. Medicare will cover that, and you will not pay whether you're in a Medicare Advantage plan or in original Medicare, with or without secondary coverage. In and outpatient services we're going to talk about in a minute. The expenditures or the cost sharing that's involved with fee-for-service Medicare and Medicare Advantage still matter. So even if it's related to COVID, just the testing is covered with no cost sharing. Telehealth has really opened up. Telehealth could mean using a video platform for a provider to speak with a patient, or it could mean just talking over the phone. A lot of people think this is not as useful as seeing somebody in person, and it is true in some ways, but we have found even over the phone with pharmacists, it can be incredibly helpful for people to speak over the phone. So we're trying to dismiss that it's totally useless. It may not be as good as in person, but it can be good, and Medicare is paying for it. They pay the same amount if you're on a video platform with your provider as if you saw them in person. And the telephone, there is a temporary, as you can imagine, people that don't have smartphones or computers or whatever, there's a huge disparity in who has access to the platform to see somebody over a video like we're doing now. So they're actually paying for telephone the same amount right now temporarily as they are if it's video platform. That may change over time because I think it could be abused. But we do worry at senior pharmacists about older adults that don't feel comfortable going in to see their provider now for obvious reasons, that are potentially having chronic conditions that are worsening, and they don't even want to talk to their doctor over the phone. We are hearing that. So we are very concerned about that. I heard recently that said care delayed is a social justice issue. We also learned in Durham, and we're going to try to work with some other people about this. Brad is on the phone. You may have some ideas about this. A lot of low-income housing in Durham, so where older adults are as well as younger people, does not have Wi-Fi. They do not have Wi-Fi, which is just shocking to me, because if you're in other complexes or senior housing like Crosdale, the Forest at Duke, obviously they have Wi-Fi everywhere. So we are still seeing incredible disparities in terms of access to care, even digitally. So we're very much wanting to work on this. But telehealth is a dramatic improvement. It used to be just for various things that would be approved, especially in rural areas. But now, obviously, it doesn't have to do with whether you're rural, rich, poor. Telehealth is available, but we are seeing a hesitancy from some people to use it. And if it's only telephone, they think it's not very useful. So that's that. Just so you know, during COVID, normally you can get a 90-day supply for most of your medicines if your provider writes a prescription that way, except for narcotics. Sometimes you can only get a 30-day supply. But most insurance companies will cover a 90-day supply, mail order or not mail order. But your provider would have to write a prescription. Now that's sort of waived. So it's not a bad idea to ask your provider to give you a 90-day supply now if you can afford it. That would be 3 monthly co-payments all at once, just FYI. And sometimes it's cheaper to get a 90-day supply than three months, 30 days, 30-day supply. So you might want to look into that. The doctor doesn't even have to be called. The pharmacist can automatically switch it because of emergency. Let me introduce you to another term called synchronicity, which is a fancy term to say, don't let me pick up my blood pressure medicine one week, my inhaler the next week, and my diabetes medicine the following week. It's asking the pharmacist to put it so that you're picking it all up at the same time. So if you're talking to your pharmacist about getting a 90-day supply, ask them to synchronize so you don't have to keep coming back and forth to the pharmacy, okay? Many of them can do that. Some of them don't. It sort of means they have to give you a short fill, like where they don't give you the full amount one time to begin with, but then you'll be on the same timetable with your medications, which helps with adherence and making sure you're not running out here and there, and you have less exposure to the pharmacy, obviously. Okay. So coverage for COVID, viral testing is covered, and in and outpatient services are covered, but there is cost sharing. So testing, no cost sharing. And the testing means the antigen, or checking for active disease, as well as the antibody, meaning to see whether you were exposed to it and developed antibodies to fight the infection. I just was tested last week myself. I had been in Botswana when all this helped and came through London and arrived back here March 19th. I was quite sick, and I was thinking I might have it, but I tested negative. I just had an antibody test and got my results yesterday. So there is testing available for people for the antigen as well as the antibody. So active disease, or whether your immune system has created antibodies. So that's no cost sharing, working with your physician to get that ordered. Some of the pharmacies and stuff are actually doing testing now, and they can also bill Medicare for that. In and outpatient services, though, if you need something related to COVID, but you're in or outpatient, you still owe. So if you're in original Medicare, you still have that cost sharing. If you have a supplement, that may pick it up. If you're Medicare Advantage plan, it just depends. Some of the Medicare Advantage plans have announced they're waiving all cost sharing related to COVID. So I know that Humana has, for example. So it just depends on the insurance company, what they're doing about it. If and when there's a vaccine that's considered medically necessary, it will be covered under Part B or Medicare Advantage plans. That's sort of all in one, and there'll be no cost sharing. So it's going to be like the flu or the pneumonia shot, not the shingle shot. Shingle shot, it's covered under Part D, and there is cost sharing with that. But for whatever reason, they're putting COVID in with the flu and the pneumonia, thank goodness. So there will be no cost sharing when that's available. So that's sort of good news that we wanted to share.